We can start. Who's presenting?
I'm presenting. Good morning, sir.
Yes. Yeah, please start. Sorry. Good morning, Dr. Kotecha. Good morning, Kulbhushan.
Hi, good morning, Prof.
Good morning. My patient is a 23-year-old male, student by occupation. He is resident of Rajasthan. He comes with chief complaints of difficulty in swallowing since 6 months, pain in abdomen since 6 months. History of presenting illness. The patient was apparently normal 6 months back when he noticed difficulty in swallowing with sensation of food being stuck in the lower chest, insidious in onset, initially requiring water along with solid food to facilitate the act of swallowing. Gradually, the dysphagia has been progressed to both solids and liquids within a period of 1 month. Patient also gives history of pain in the abdomen since 6 months, insidious in onset, upper abdomen in the epigastric region, intermittent, moderate intensity, burning type of pain. It is aggravated after food intake, relieved spontaneously or with medications occasionally. He also gives history of regurgitation, especially after consuming solid or semi-solid food. He gives a history of unintentional weight loss with an associated history of loss of appetite since 3 months. Patient gives no history of odonophagia or painful swallowing, bad breath, halitosis, neck swelling, gurgling sound while swallowing, difficulty in initiating the swallowing, dysarthria or nasal regurgitation, associated chest pain or postural modification to facilitate food or relation to temperature of food. There is no previous history of corrosive intake, no history of hematemesis or melena. There is no history of cough with expectoration or recurrent upper respiratory tract infections. There is no history of coughing or choking after swallowing. There is no history of abdominal distension, respiratory discomfort, dyspnea, bone pain, back pain, blackout, or seizures. There is no history of hoarseness of voice or stridor. Patient with the above complaints had undergone evaluation with an upper GI endoscope at a local hospital. He is diagnosed to have malignancy, received 4 cycles of chemotherapy with no documented adverse events of chemotherapy. There was relief of symptoms post chemotherapy. He has presented here for further management. Past history, there is no history of tuberculosis, asthma, hypertension, COPD. Family history, there is no significant family history or cancer-related deaths. Personal history, patient consumes mixed diet, normal bowel and bladder habits, sleep is undisturbed, there are no addictions. Coming to summary, my patient is a 23-year-old male with no comorbidities, comes with complaints of short duration progressive dysphagia, initially for solids, later progressed to both solids and liquids, with pain in the upper abdomen along with symptoms of reflux disease since 6 months, associated with significant loss of weight and loss of appetite. Status post 4 cycles of chemotherapy following an upper GI endoscopy with relief of symptoms post chemotherapy. I would like to give my differential diagnosis depending on my history, sir. It's a malignant dysphagia secondary to carcinoma of lower esophagus or carcinoma of GE junction.
So here, of course, since there is history of biopsy followed by chemotherapy, there is no doubt about the diagnosis. But for the sake of discussion, let us exclude that history.
Okay,
So
sir.
let us presume that he did not undergo an upper GI endoscopy and biopsy, and he has not received chemotherapy.
Yes,
So
sir.
if he came to you before this, what will be your
Yes.
interpretation?
Sir, I would like to think more in terms of benign pathology, sir.
Yeah, that's very important. So even if
Yes.
you know the diagnosis, and this is an example of a case where if you know the diagnosis and if you try to justify it in the exam, most probably you will falter.
Yes.
So that is why I always say that in the exam, make an effort not to try to know the diagnosis. And if your senior colleague or friend is appearing in the exam, if you tell him or her the diagnosis, you are not doing him a favor. You are putting
Yes.
the person in trouble. So if that history of biopsy and chemotherapy is not there, you are right.
Yes.
You cannot make or you should not make a diagnosis of malignancy here. Okay?
Yes.
Yeah.
Yes.
So you say benign. What benign cause?
Sir, considering his history, more probably I would think in terms of reflex esophagitis with maybe stricture esophagus.
Let's go back
Or,
to the history of symptoms of reflux. Yeah. So how would you make a diagnosis of reflux esophagitis causing an esophageal stricture? What will be the course or sequence of events?
Sir, it is a long duration course, sir, actually. Patient most often present with symptoms of peptic ulcer disease, and he has burning epigastric pain with associated postprandial fullness, abdominal distension immediately after taking food, with repeated episodes of reflux and regurgitation of food contents into the mouth, following which he might present with insidious onset, not progressive dysphagia, sir. It could be a dysphagia which has a chronic onset or chronic long course durations.
How is peptic ulcer disease related to dysphagia? Why did you bring peptic ulcer disease into discussion?
Uh, Not peptic ulcer disease, sir. Reflux esophagitis could be a peptic ulcer disease could be an associated finding, sir.
Maybe, but you should not. Peptic ulcer disease will give rise to gastric outlet obstruction. That is a different
Yes,
story altogether. Here you are thinking of reflux esophagitis, which
yes,
is
sir.
causing a peptic stricture. It is called peptic stricture, but it is not peptic ulcer disease.
Yes, yes,
Okay, so it's some kind of a misnomer, although it is related to acid. That is why it is called peptic stricture, but it is
yes,
reflux esophagitis. So
yes.
what fits in with the history of reflux esophagitis here and what doesn't fit in?
Sir, there is regurgitation of food contents, sir, especially solid and semi-solid food. Apart from that,
Mhm.
abdominal pain in the epigastrium, he has, sir, actually, in the upper abdomen. Apart from that, the other symptoms of reflux, such as postprandial fullness or distension of abdomen and repeated episodes of reflux of contents, typical history is not present, sir. Associated findings.
What is the classical history of reflux esophagitis or gastroesophageal reflux disease?
Sir, there is bloating, sir,
No.
and fullness. Uh,
Bloating is not the symptom of reflux. What is the symptom of reflux esophagitis? It is retrosternal burning. It is not
Retrosternal burning
epigastric
pain.
pain.
The
Epigastric
retrosternal.
pain is more suggestive of peptic ulcer disease or other
Yes, sir.
causes. The classical or typical history or presentation of reflux esophagitis is retrosternal burning, sour eructation, and yeah, there may be bleeding in some
Yes, sir.
cases. And then
Yes.
these patients may even present with symptoms related to unrelated organs. For example, they may have recurrent aspiration, which they haven't been able to notice, and they can present as chest infection. Some patients may present as inflammation of the vocal cord with speech
Yes, sir.
disturbance. With severe reflux, they may even present to ENT department with ear and no this ear problems, blocked
Yes.
eustachian tubes and all. So
Yes.
many children who have gastroesophageal reflux, they are misdiagnosed as bronchitis or bronchial asthma because of bronchospasm of because caused by recurrent aspiration. So
Yes, sir. Mm.
the typical presentation of reflux esophagitis is retrosternal burning and
Yes.
pain. But pain
Pain.
is in
Yes.
the retrosternal area, not in the epigastrium. And then these
Yes.
symptoms should be there for a long time before they result in formation of a stricture at the
Picture.
lower end of the esophagus, which then presents with dysphagia. So the history here is not very typical of reflux
Yes, sir.
esophagitis and a peptic stricture. What else benign cause?
Um, Sir, I could think in terms of motility disorders, especially
Mhm.
could be
So
a
what is in favor
acute.
of motility disorder and what is against a motility disorder?
First thing is patient is an engaged fellow, 23-year-old, and then
Yes.
he presented with symptoms of insidious onset dysphagia, sir. And he has dysphagia both,
The
especially if
onset will be insidious in malignancy also. In no condition you will have a sudden onset dysphagia.
so,
Which condition will cause a sudden onset dysphagia? That till yesterday patient was eating food normally and today he says that I can't eat. What is that
so the
condition?
Shatsky's ring, sir. In that condition, there
Sorry?
could be sudden food impaction can lead to sudden onset dysphagia, sir, of aphasia.
Why should it cause sudden onset that till yesterday patient was eating and today he says I can't eat? The only condition which would probably cause a sudden onset dysphagia is that there is some narrowing pre-existing which was not causing significant dysphagia, and then there is a bolus impaction. So patient swallows say, say a piece of meat which is not properly chewed, or a fruit which has a lot of fiber or pith, or a large seed
Yes.
gets impacted there. So bolus impaction is the only condition which will cause sudden onset dysphagia in a patient who has some narrowing. Because if you have a normal esophagus with normal motility,
Yes, sir.
there is no reason why bolus should get impacted. Bolus gets impacted only if there is some narrowing of the esophagus. So
Yes.
most patients with dysphagia will have an insidious history, whether it is benign or malignant. Only difference is, if the history is very long, you think of a benign condition. If the history is short, it could be either. It could be benign or it could be malignant. So what are the
Malignant.
points against a motility disorder here?
Sir, it is progressive dysphagia, sir, first thing. And then initially it started with solids, sir, and then later progressed to liquids also. So the
Yeah.
progressive dysphagia had short duration with history of, loss of appetite more importantly, sir. Loss of weight could be there in any patient with
Yes.
dysphagia secondary to pathology.
So dysphagia starting for solids and then progressing to semi-solid or liquid is
Yes.
not against the diagnosis of motility disorder. But if the reverse is there, that initially the patient has difficulty in swallowing liquids, but he says, I
Yes.
can swallow solids normally, that is a point in favor. So not all patients have that classical history.
Yes.
So points which favor a motility disorder are young age, long duration of symptoms, intermittent dysphagia, that some days or some weeks dysphagia is there and then the patient feels all right. If
Yes.
it starts with difficulty in swallowing for liquids and then progresses to solids, the reverse order, and
Yes.
some patients give this history that they have more dysphagia with cold or hot food. They can swallow in a certain position or by doing certain maneuvers. If these points are there, they are points in favor of a motility disorder. But if they are not there, it doesn't mean that it cannot be motility disorder. So what I'm trying to say, even a middle-aged or elderly person who has insidious onset progressive dysphagia starting for solids, then going to semi-solids and liquids, can still be motility disorder.
Motility
Can
disorder.
still be
Yes.
motility disorder. Yes, you were
Yes.
right that loss of appetite is not there in motility disorder. In motility disorder, patient has appetite, he wants to eat food, but he has difficulty in eating food. And then
Yes.
because of decreased intake, there is loss of weight. So loss of weight can be there, but loss of appetite is not there in a benign dysphagia. Okay.
Yes. Yes.
Any other benign cause you can think of? Uncommon, rare, but you may have to keep it at the back of your mind.
External
Disease
compression.
Yes. Hmm?
External compression due to mediastinitis or mediastinal lymph node enlargement secondary to his
Yes.
respiratory.
Yes. Especially in our setup, when you have a young patient and you cannot find any other common cause of dysphagia, you
Yes.
have to keep at the back. I'm not saying that you make a clinical diagnosis, because that is not a clinical diagnosis, but you have to keep the possibility in mind that this could be an extrinsic compression, especially by nodes, mediastinal nodes, which in our setup are tubercular. So that possibility you have to keep in mind, but don't make a clinical diagnosis of tubercular nodes causing dysphagia. A caution point about corrosive intake. See, somebody who has taken corrosive intentionally with an intent to commit suicide may not,
Yes.
in the first instance, come forward with the history. So you have to be
Yes.
very careful. You have to gain the confidence of the patient. This is important for your clinical practice also. And
Yes, sir.
once the patient has confidence in you, then he or she will tell you that, yes, I did it. But in the first instance, the patient may not conceal that history because she doesn't want to tell the relatives that she did it. So you have to be careful about that. Okay?
Yes. Yes.
Fine. John, let's move on.
Shall I proceed to examination findings?
Yes.
General physical examinations. Patient is averagely built and nourished. He is alert, conscious, cooperative, well oriented to time, place, and person. Is lying comfortably on bed. His ECOG performance status score is 1. His BMI of 23.3 kg per meter square. Is AFib at the time of examination. All the vitals are, pulse is, heart rate is 78 beats per minute. Blood pressure is 128 by 76 millimeters of mercury. Saturation is 98% under room air. And respiratory rate is 15 breaths per minute. Breath holding time is 30 seconds. There is no pallor, icterus, bilateral supraclavicular lymph nodes, or any other cervical lymph nodes palpable. There is no clubbing, cyanosis, pedal edema. There were no signs of dehydration notice at the time of examination. Oral cavity examination shows adequate mouth opening with good oral hygiene maintained. There is no halitosis, mucosal lesions noticed in oral cavity examination. Coming to local examination per abdominal, the inspection, the abdomen is flat, umbilicus is centered in position, midline and inverted. All the quadrants move
So,
equally
okay,
with respiration.
let's skip this. Just tell if there's any positive finding.
No, sir. There are no positive findings. As such, respiratory examination finding also have done, sir. Inspection and palpation, percussion showed no other abnormal findings, sir, as such.
Yeah,
And rest of
good
the
that you
system.
describe the respiratory system in detail, because in any patient with dysphagia, actually chest is more important than abdomen. So in the exam also, you should describe the respiratory system in great detail to emphasize that you have looked for features of aspiration and pneumonitis. One more point which I forgot to mention, that in any patient who is young and whose
Yes.
clinical history or examination findings suggest the possibility of a malignancy, you have to
Yes.
keep the possibility of a lymphoma in mind. Okay. So
Yes.
whenever you have a young patient who you think based on history you would like to make a diagnosis of malignancy, you have to keep lymphoma in mind. That will be further strengthened by the fact that on endoscopy you find the mucosa to be normal, whether it is stomach or rectum or colon, and on imaging, CT or MRI, you will find diffuse circumferential thickening of the wall of the viscus. So if these, and endoscopic biopsies will be repeatedly negative because they are mucosal biopsies. So if that is the situation, you start thinking of a possibility of a lymphoma.
Yes.
Okay, so here obviously the diagnosis is obvious, so we would not go into those details. But as I said, that there are some points which can differentiate between a benign and a malignant dysphagia.
Yes.
Let's see the investigation findings.
Yes, sir. These are the blood investigations which we have done, sir, on admission. It's all the investigations are within normal limits. His hemoglobin is 12.1. Even his liver function status are normal, especially albumin is 3.5, good nutritionally preserved patients. And urea creatinine and the rest of the electrolytes and viral seromarkers are negative, even INR, everything was in normal limits.
Yes. Carry on.
Sir, I would like to review the previous medical reports of the patient, sir, where he has undergone initial evaluation before starting chemotherapy. So I would like to take the reports from there. In that, the previous endoscopic report, which was done before initiating chemotherapy, has been this, sir. Actually, it is completely. It is incomplete report, sir. Actually, they have not mentioned any specific features which are suggestive. They have just mentioned that there is a growth which is seen with irregular mucosa at GE junction involving the fundus. Apart from that, they've drawn a diagram showing the extent of the tumor, sir, from where near the GE junction just above till below, occupying the lesser curvature and fundus of the stomach. Apart from that, they have not mentioned anything.
They mentioned some small nodules at D1, D2 junction.
Yes, sir. D1, D2 has shown small nodules. And
Did they take a biopsy from there?
yes, sir, they have taken the biopsy, sir. And this is the biopsy report, sir, actually. And then they have just it was consistent with the feature suggestive of adenocarcinomas. The differentiation grading they have not mentioned here, sir. And they've just said
I was
it's
asking whether they took a biopsy from the duodenal nodule.
no, sir, they have not taken, sir.
Why have they asked for immunohistochemistry?
Sir, the details are not available with us, sir, actually. For final diagnosis, they've considered asking, but the features,
Histology.
whatever they have mentioned, sir.
histology should be good enough to say that or confirm that it is adenocarcinoma. Two reasons.
Yes.
One, because the patient is very young. I'm sure the pathologist also had this point at the back of mind that whether it is adenocarcinoma or a lymphoma. And number two, I don't know whether differentiation is mentioned, but if you have a poorly differentiated adenocarcinoma, then
Yes, sir.
even for a experienced pathologist, it may be difficult to differentiate it from a lymphoma. So that is why they usually ask for a immunohistochemistry, because there are different IHC markers for adenocarcinoma and
Yes.
different organs and different IHC markers for lymphoma. So in that
Yes.
situation, IHC can differentiate between a poorly differentiated adenocarcinoma and a lymphoma. Okay, next.
So this was a biopsy report, and patient had undergone evaluation with CT scan, sir, before initiating chemotherapy.
Do we
This
have
was a
the
CT
film?
report.
Do we have the
Sir,
film?
yes, once.
Yeah, let's see the film first.
Um, there were
This is
areas
not
of
CT.
hypermetabolic. Sir,
This is not CT. He had
CT,
a
sir,
CT or
CT,
a PET?
PET CT only, sir. I had PET CT actually.
Okay, okay. Yes, show.
So the report, sir.
No, no, show. Explain the film. What do you see in the film?
Sir, there was PET-CT of the whole body shows that there's a hypermetabolic response noted at the G junction and along the lesser curvature of the stomach, sir. And there is one more metabolic response which is noted just at the level of pancreas near the celiac axis. Sir. This could be a possible likely metastatic lymph node which is seen here. Sir. So these are the findings which were consistent with, apart from that, rest of the abdomen, liver, peritoneal surface, lungs, cervical lymph node area have not shown uh, any other activities.
But there is a metastasis in the brain. Brain is showing activity.
No, sir. The CSF fluid is usually hyperintensive metabolic fluid, metabolic activity it will show, sir, but it should not be taken or considered
In
consistent with the.
normal, yeah, you should say this is the normal physiological avidity of the brain. So brain, heart, and urinary bladder. You can see the urinary bladder also in the last quadrant.
Yes,
Again,
yes,
you
sir. Here,
see this
yes.
is normal physiological avidity. Do we have the CT films of the PET CT? No.
No, no, sir. They have not provided any PET-CT films, sir,
Okay.
actually.
Let's
And then,
see the report.
sir, this is a report, sir. Before
Yes.
initiating, there is a hypermetabolic circumferential irregular enhancing wall thickening involving GE junction and gastric cardia along the lesser curvature, likely primary malignant disease. Hypermetabolic lymphadenopathy is seen in gastrohepatic and peripancreatic regions, likely nodal metastasis. There is no other metabolically active lesion noticed elsewhere in the whole body PET-CT survey. And then he has underwent 4 cycles of chemotherapies, after which flawed regimen,
So
actually.
the pathologist said advised immunohistochemistry. Was it done? No.
No, sir, it wasn't done.
So in this case,
Yes.
he's a 23-year-old boy who had an endoscopic biopsy proven adenocarcinoma. Would you
Yes.
straight away go for a PET CT or would you do something else?
Sir, I would initially like to get an ultrasound done first, sir.
Yeah, very important. A young patient with malignancy, we know that most of the malignancies, especially adenocarcinomas, when they occur in
Yes.
the young age, they are more aggressive. So I would also prefer to do a chest X-ray and an ultrasound first
Ultrasound.
before going
Yes.
for an expensive investigation, because suppose ultrasound shows a liver as well or a chest X-ray shows a pulmonary nodule, then
Yes.
probably you would not go and do a CT or a PET scan unless it is for monitoring purposes, because you know you are dealing with metastatic disease. So whenever you see a young patient with a proven malignancy, your clinical examination should be very meticulous, including
Yes.
left supraclavicular lymph node, careful palpation of the umbilicus for a nodule, good per rectal and per vaginal examination to make sure that you are not missing any metastasis clinically. And then the first set of, in fact, some examiners would want that in any malignancy, before you go for CT, MRI, PET scan, or US, you should always mention a chest X-ray and an ultrasound first, because they are
Yes.
inexpensive investigations. And if they show metastasis, in most cases, you may not have to proceed further. So that
Yes.
precaution you need to take both in the exam and in your clinical practice also. Yes.
Yeah.
Okay. So then what treatment did he receive?
Sir, he received 4 cycles of FLOT regimen of chemotherapies.
What is FLOT?
Sir, FLOT regimen consists of constellation of 4 drugs, sir, which includes 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel. It is a perioperative chemotherapy, especially in G junction and gastric or esophageal adenocarcinomas. It's a proven, showed better result regimens.
I think it is for squamous cell also. Now FLOT is accepted. Just check
FLOT.
on that. Yeah.
Okay.
So do we have a so you gave 4 cycles of chemotherapy and you said he had improvement in dysphagia, isn't it?
Symptoms of dysphagia have improved.
How else would you assess the response to chemotherapy, neoadjuvant?
Sir, the response is one clinical criteria, sir, and the second radiologically, again, I would like to get a PET-CT scan post 4 to 6 weeks after the fourth cycle or last cycle of chemotherapy neoadjuvant period, sir. And then I would assess the degree of shrinkage of the tumor and the response of the tumors and the metabolic activity, whether it has reduced compared to previous thing.
So that's all. Any other? How do you assess response to
I would-
neoadjuvant chemotherapy in general? Not here, in general.
In especially in esophageal carcinomas, one is clinical, sir. Second one, I will do a redo endoscopy and then look for the. I'll just correlate the findings prior to chemotherapy, and then if needed, I'll take a biopsy and then send for histopathological evaluations.
Yeah, so your answer should be that the response to neoadjuvant chemotherapy can be assessed in several ways. Clinical, which is dysphagia. If the patient was bleeding, say a colorectal growth, that could be bleeding. Second, radiological, which is anatomical, so CT scan, that what is the change in the volume of the or size of the tumor. Okay.
Yes.
Third is endoscopic. So suppose the growth was not passable earlier and now you can pass the scope, or there was a
Yes.
large polypoidal growth which has reduced in size or is not there. Fourth could be histological. You do a biopsy and it is negative. Fifth could be biological, which is PET scan. How much was the avidity earlier and how much is the avidity now? Biological could also be tumor marker. Here, of course, we don't have a tumor marker, but for example, in pancreas, CA99 level, in colorectal malignancy, CEA level could be measured. So it could be clinical, anatomical, which is imaging, endoscopic, histological, and biological. Biological could be imaging or biochemical. That is what you should say, that these are the standard ways by which you assess the response to neoadjuvant chemotherapy. Okay. So in his case, was any assessment done post chemotherapy?
Yes, sir. We have done endoscopy, CT as well as PET-CT. CT was done before doing a PET-CT by radiologist, sir. And then we have considered chest X-ray and ultrasound abdomen first, sir, when he was presented to our department. Both of them showed no gross abnormalities, sir. Everything was within normal limits. This was his chest X-ray, sir. As such, there were no metastatic deposits noticed or abnormal findings within the chest X-ray. And this was the endoscopy, which was done in our settings, sir, actually. In esophagus, the GE junction is noted at 38 centimeters from the incisors. There were no erosions varix. An ulcerated growth is seen at GE junction, which is approximately the mentioned 5 into 2 centimeters. This was a finding where we can see the ulcer from the GE junction. Partially, apart from that, corpus, fundus, antrum, and pylorus, everything they have mentioned that visualized mucosa appears normal. There were no erosions or ulcers seen. And here in our this thing, there were no nodules seen in duodenum, sir. Actually, first or second part of the duodenum. So final report was ulceroproliferative growth 5 to 2 centimeters just above the GE junction is what they mentioned.
So endoscopically, would you say that there is response or no response?
Sir, I would say it is response, sir. Actually, the ulceroproliferative growth as such seems to be shrunken in size, and then the GE junction is well opened. Actually, there is no complete luminal obstruction all around, and then scope could be easily negotiated into the stomach where we could reach up to duodenum and can assess further distally in the stomach and everywhere else. I mean, other areas, sir. When he had presented with progressive dysphagia of both solids and liquids at that point of time, taking that history and endoscopic findings, can say it has responded.
But the scope was possible earlier also, because earlier also
Yes.
they evaluated the stomach and duodenum.
Yes.
So they have not mentioned the size in the earlier endoscopy. So you cannot comment whether size has reduced, but only change is that earlier they mentioned, and they drew the diagram also, that the growth was in the esophagus as well as in the lesser curvature and fundus of the stomach. And now the
Yes.
fundus of the stomach and the body of the stomach are normal. So that is an indication that there is some response. It is a partial response because the growth is still there. But yes, based on that, we can say that there is some response.
Yes.
Next.
Sir, we have done a PET CT, sir. Before that, there were initial CT films are there. So I would like to show that video, sir.
So is a PET CT, a repeat PET CT always required after neoadjuvant chemotherapy?
No, sir. Actually, I mean, to assess the response, if patient has undergone previously PET CT, so we would like to consider again, sir, because of
So
4 cycles of.
there are two schools of thought on this. There are some people who would say that if initially the lesion was technically resectable, but you gave neoadjuvant chemotherapy only as a part of a protocol, then, and if the patient shows clinical response, then in all likelihood, the repeat PET CT also will show response. So to save some costs, they would not repeat a PET CT. But theoretically speaking, yes, every patient should have a re-evaluation, because there is a small possibility that although the primary tumor has shown response, there may be a distant spread, which is less likely. So that is the reason why most people would, if cost is not a constraint, they would do a re-evaluation with a PET CT also. Let's see.
Yes, sir, I would like to show the PET CT video, sir. 1 second, I'll share it.
Yes, Kulbhushan, you want to add anything?
Sir, I want to ask one question. Sir, aperture endoscopy is do necessary in all cases after giving the neoadjuvant therapy, or we can assess only by clinical or radiological response?
Raghavendra, you want to take that? Raghavendra, did you hear the question asked by Dr. Kulbhushan? He's not. Did you get the question asked by Dr. Kulbhushan? He asked that whether a repeat endoscopy is always required if the patient has shown clinical response.
Sir.
Do you want to do a repeat endoscopy?
Yes, sir. I would like to consider seeing the repeat endoscopy, sir. If patient could be there could be any skip lesions present, sir. Actually, could be a possibility whether there is a secondary primary could have been developed with 4 to 6 weeks of treatment, or just to, I mean, also to assess whether clinically also how much the tumor shrinkage is present in these cases, and also if there is complete clinical response. The recent trials, even we can take biopsy and show if there is no malignancy detected at the previous site where there was malignancy seen in PET CT. If there is complete clinical response, there we can provide them a wait and watch policy also, sir. In considering these cases, we can do a repeat endoscopy and biopsy if required.
So in adenocarcinoma, is chemotherapy alone a complete treatment?
No, sir. Adenocarcinomas usually it's not a complete treatment. So
that option is there only in squamous cell carcinoma, and there also, if you have given definitive chemoradiotherapy, not chemotherapy, definitive chemoradiotherapy is an option. But then the dosage of radiotherapy for neoadjuvant versus definitive are different. And if you have given neoadjuvant chemoradiotherapy in a patient with squamous cell carcinoma of the esophagus, you will have to wait. If you are giving radiotherapy, you will have to wait at least for 4 to 6 weeks before you reassess, because that is the time for radiation to take. Now, if you decide not to operate upon the patient, after that much gap, you cannot add radiotherapy. I don't know how many of you attended the last class by Dr. Anushri on principles of radiotherapy, and this issue was discussed there. That if you have
Yes.
given neoadjuvant chemoradiotherapy, which involves a lower dose, I think about 40 something, then there is a gap before you reevaluate. And if the patient doesn't want surgery, or if you want to wait and watch, you cannot give more radiotherapy. You can maybe continue chemotherapy, but that option is there only in squamous cell carcinoma of the esophagus, and it is also
Yes.
not an accepted option. It is not the standard of care, as opposed to the Haber gamma regime in CA rectum, where
Yes, sir.
if you have a complete clinical, radiological, histological, and other responses, there is a policy of
Yes.
wait and watch, which actually is a proactive surveillance. You keep the patient under very close follow-up, and at any evidence of recurrence of the disease, you will have to
Yes.
reoperate upon them. So
Okay.
yes, in esophagus, some people have used this policy of what they call
Yes.
salvage surgery, that if there is a recurrence after initial complete response, then
Yes.
you could follow it. But I presume that is mainly for squamous cell carcinoma,
From a
not
cell
for
carcinoma.
adenoma. And
Yes.
you mentioned skip lesions. Now, skip lesions are seen in adenocarcinoma.
No, sir. Squamous cell carcinoma.
They are more in squamous cell carcinoma,
Squamous
and
cell
they are
carcinoma.
basically not skip lesions. They are
Skip
submucosal deposits because of the
deposits.
spread by submucosal lymphatics. So there could be proximal submucosal deposits, and that is why whenever you are operating for squamous cell carcinoma, it is recommended that you have a 10 centimeter margin proximal, whereas for
Yes.
adenocarcinoma, you need only 5 centimeter margin.
5
And
centimeters.
that is why for squamous cell carcinoma, it is almost always a subtotal esophagectomy, not a partial
Yes.
esophagectomy. Yeah. Let's see
Yes.
the video.
So this is oral plus IV contrast.
No, we don't see. We are only seeing your folder. I think stop sharing and share again. Earlier we
Okay,
were
sir.
seeing it.
Okay, sir. I'll share. So this is oral plus IV contrast CCT of chest and abdomen, sir. We can see the trachea and bronchus at this point of time, and then we can see the contrast within the esophageal lumen, which is just passing the. There are well maintained planes with the aorta and anterior with the pericardium. At this point, there is start of thickening of the esophageal wall, sir. There is still the contrast is persisting. Again, there is complete luminal uh, narrowing with thickening of the esophageal wall. And then once we enter from this point, sir, we can see there is entire thickening of the esophageal wall with no contrast within the lumen seen actually. And then this is a area of gas G junction where we can see entirely it is filled with hypodense lesions, sir. Here it seems to be extending into the cardiac and lesser curvature of the stomach at this point of the area, and then rest of the liver appears normal with no suspicious nodules, and then the rest of the stomach below that seems to be normal, sir. And previously mentioned area of lymph nodes along the celiac axis. Here at this point we can see there is a suspicious lymph node at the origin of the celiac artery, sir, just above sitting it, abutting the body of the pancreas, sir. Apart from that, rest of the abdomen appears to be normal, sir. As such, the peritoneal surface CT is not that sensitive, but grossly the rest of the peritoneal cavity, everything's appears to be normal, sir, except for this part of the area where the mass seems to be there at the GE junction, extending proximally into the esophagus a little bit, but within the intra-abdominal part of the esophagus, because everything is seen below the hiatus, sir. I would like to show coronal
No,
section
stay
also,
on.
sir.
Stay on. Hold on. Go back to the chest. So there is no growth there where you were saying that the plane with aorta and pericardium. This is
This
normal
one,
esophagus. Go
this is
slowly go
normally, sir.
down. Yeah,
Yes,
this is
from
normal
here also
collapsed esophagus.
normally.
Now, this is
Yes,
where you start seeing some irregular thickening.
thickening
Yeah,
from this point.
this is where probably the growth starts, not
Yes.
in the higher cuts. And then yes, you are right. At least in the CT, it appears that a part of the lesser curve and a small part of the fundus are involved. Although an endoscopy, they said normal. So how do you explain that? Here we are seeing some thickening in the lesser curve, but on endoscopy, it is said that it is normal.
Yeah. Yes, sir. The thickening, most probably the mucosal surface maybe would have appeared normal, sir. But
Yeah,
on J
so
manual,
mucosal lesion
but
has
there is
healed, and adenocarcinoma of the GE junction is known to have a contiguous
some,
submucosal spread. So it is
yes,
possible that mucosa may be normal, but there is a growth which is extending in the submucosal plane, and that is what explains the discrepancy between the imaging and endoscopy. Endoscopy looks only at the mucosa, whereas any
mucosal.
cross-sectional imaging looks at the wall, the full
Yeah.
thickness of the wall. Okay.
Yes. Yes.
Yeah. So since we have only 5 minutes left, let me ask you a direct question. So in this
Okay,
case, now what will be your plan of management?
sir. In this case, because of the response, I would like to go for total D2 radical gastrectomies.
Total? Say again.
So D2 total radical gastrectomies.
So what is this is adenocarcinoma of the esophagus, GE junction, or stomach?
Sir, it is a G junction, sir, and
If it is GE
with
junction,
fever type 3.
yes.
Fever type 3, sir.
Why do you say type 3? What is type 3?
Because a part of, sir, part of one second. Type 3 is a fever epicenter of the tumor is 2 centimeters beyond into the stomach beyond the GE junction to 5 centimeters beyond the GE junction into the stomach.
Yeah, so although we don't have the pre-chemotherapy cross-sectional imaging or a very good endoscopy report, but based on the current image which you showed, do
Yes,
you
sir.
think it is a type 3 lesion?
Sir, it looks more of actually type 2, sir, fever type 2.
Yeah, here it looks more like type 2 because the epicenter, it is the epicenter. Epicenter of the tumor is within 1 to 2 centimeter of the GE junction, isn't it? So it is
Yes,
more like a type 2. You were right
2.
that if it is type 3, it is to be treated like CA stomach. If it is
Yes,
type 1, it is to be treated like CA esophagus. But type 2
esophagus.
is the most debatable issue. So what is the
Yes.
correct surgical management of a type 2, severe type 2 adenocarcinoma of the GE junction?
It is actually VATS, thoracoscopic esophageal mobilization esophagectomy with gastric conduit and esophagogastric anastomosis in the neck or
Yeah,
thorax
so
could be either.
management of
Whoever ways.
severe type 2 is very debatable, very controversial. It could be from a very aggressive approach where some people would do a subtotal esophago total gastrectomy
Gastrectomy. Yes.
and do reconstruction using colon with a
Yes.
cervical anastomosis. So that is one extreme. Other extreme is that you do a partial esophago, partial proximal gastrectomy with
Yes.
5 centimeter proximal and 4 or 5 centimeter distal margin, depending on how
Yes.
much of the lesser curve is involved. That is the most conservative approach. Now, in between, most people would go for a total gastrectomy, but a partial esophagectomy. And very few
Yes.
people, almost none, would go for a subtotal esophagectomy and partial gastrectomy. So if you want to be
Yes.
aggressive, you have to be aggressive more on the stomach side because in
Stomach.
adenocarcinoma, as I said earlier, proximal margin required is only 5 centimeter.
5 centimeters.
So
Yes.
you can easily do a subcarinal anastomosis, and that is why some people would use a left thoracoabdominal approach, not right,
Yes.
left thoracoabdominal approach, where you open the chest, you open the diaphragm, so
Yeah.
you convert the pleural and peritoneal cavity into one, and now you
Yes.
do a partial esophago total gastrectomy with lymph node dissection, as you said, and then you reconstruct using an interposition there.
Yes.
Or you do a esophagojejunostomy, but it becomes a subcarinal anastomosis.
Anastomosis. Yes.
Yeah. But having a totally abdominal approach
Yes.
and doing a total gastrectomy alone in a severe type 2 would not be acceptable. You have to get 5 centimeter proximal margin, which will be almost impossible unless you get into the chest.
Chest, yes.
Yeah.
Yes.
Any questions?
That's what Sievert type 2, if at all, if we encounter, sir, so it is all subjective to the surgeon that what he has to plan, sir, accordingly. In this case, if suppose in this case, what would be the ideal, sir, actually? It could be Ivor Lewis or modified Ivor Lewis left thoraco-abdominal approach, or McEwan's with gastric conduit we can create.
As I said, it would depend on your philosophy. The different people have different philosophies. If you want to do a subtotal esophagectomy, obviously it will be either a McEwan, or if you could even do transhiatal, you could do a thoracoscopic approach. So depending on, whenever you describe any procedure related to esophagus, you must say how much of the esophagus and how much of the stomach is to be removed, what approach you are going to use to mobilize the esophagus, whether it is transthoracic or transhiatal. If it is transthoracic, whether it is thoracotomy or thoracoscopic, you have to say which conduit you will use. You have to say where you will do the anastomosis, whether in the neck or in the chest. If it is in the chest, whether it is the apex of the thoracic inlet, which is from the right side, or whether it is subcarinal, which is from the left side. And you have to say what will be the extent of lymphadenectomy, both in relation to esophagus and in relation to stomach. That will be the complete description of a surgical procedure for any esophageal or a G-junction lesion.
Okay, sir. Yes. Thank you, sir.
Any other students would like to ask anything, or anybody would like to make a comment? Okay, so students, please send me a mail, vkkapoor.india@gmail.com. Write esophagus in the subject of the mail. So I'll send you the chapter on esophagus from the operative surgery book.
Okay, sure.
Okay.
Thank you, sir.
Thank you, Raghavendra. Thank you very much.
Thank you.
Thank you.
Thank you.